Hi, everybody. My name is Amanda Sisco. I am the Supervisor of Oncology Services for Colorado Retina Associates. I work directly with Dr. Peter Hovland and our ocular oncology team here. I have been in this industry for about 6, 7 years now, working directly with ocular melanoma patients. And I've been volunteering and working with the Melanoma Research Foundation for about 5 years. In my travels or in my experience, I've come across a lot of different issues with patients, insurance, treatment choices, things like that. And so today we're just going to be talking a little bit about how you can be your own best advocate in a clinical setting. So I am going to share my screen and get started on some of these slides that I have prepared for you guys. So first, like we talked about, we're going over the self-advocacy in a clinical setting. And of course, my name is Amanda, and I'm the Supervisor of Oncology Services at Colorado Retina. By the way, if you have any questions or anything like that, you can go ahead and put those in the chat, and I will answer those as soon as I can. So first, what are our objectives today? So we want to understand what self-advocacy means. What are some practical applications of self-advocacy in a clinical setting? Understanding who everybody is in your treatment team, what the recommendations are for imaging, and what to do if you move to a new doctor, and what is adjuvant therapy. So first, what is self-advocacy? Advocacy for yourself is asking for what you need and what you want while understanding the difference between the two. So what you need is the absolute necessities. You need quality care, you need safety, you need to have your illness or disease treated properly according to at least the standards of care. What you want is you want proper bedside manner. You want to have all of the research options open to you or things like that. So there's a varying difference between those two, necessity being need and desire being want. It's also the ability to make informed choices and understanding of the possible outcomes of those choices. So if a physician presents different treatment options to you, being able to understand what those mean and what the possible consequences of each of those are. It's also knowledge and understanding of your rights and responsibilities as a patient, and communicating your goals clearly to your treatment team, whether that be your ocular oncologist, medical oncologist, even your primary care doctor. If you have a specific goal for where you want to be in your health journey a year from now, 6 months from now, being able to communicate that to them clearly. So this is a list of just some things you can do to advocate for yourself while you're in the clinic. Number one, always ask questions. If you don't understand why or how something is happening or something is going to happen, ask. You have every right to fully understand your plan and your care. I recommend to bring a notebook with you to write things down, especially if you don't have somebody with you. There's always that shock when we're in a doctor's office, and even myself, I forget half of what they went over by the time I get out to my car. Bring someone with you to ask the questions that you don't think of. Obviously, we're in the middle of a pandemic, so pandemic permitting, bring someone with you. Also, a lot of offices will allow you to have somebody on speakerphone if they have to wait outside. So that's another option as well. Often I hear from a lot of patients that they're going to a different specialist and they have trouble getting all of their records sent over, things like that. Always request a copy of your note at each visit. So when you're done seeing the doctor, they sign off on your notes, and you should always request a copy of that. That just has the information that you need if you have to go and see somebody else, so that they can get the history of where you're at in your treatment. Same thing goes for when you're getting imaging done, whether it be an MRI, an X-ray, a CT scan. Always request a disc with the images for your records. So I recommend you do that because As connected as everybody is in this world, we're not as connected when it comes to electronic health record systems. So, for example, if we send a patient to get imaging at Envision Sally Joe, we have to rely on the fact that they'll send us the report and that it will be absolutely comprehensive. Now, if a patient gets their disc, which they can get immediately once the scan is done, we always have that as a backup to look over. So I always recommend you keep a copy of your discs. And always, before meeting with a new doctor or having a new procedure, ask if there has been insurance authorization. Ask if everyone is in network. If they say they don't know or will have to see, that is not a good answer. We want to make sure everything is in network with your insurance. Otherwise, that falls on you. There's no, well, my doctor didn't check, so I shouldn't be responsible. Unfortunately, the fault always lies with the patient for not checking, which is not fair, but that's just the way insurance runs these days. So another thing you can do is develop a plan. So having the next steps planned out in your treatment journey can really make the current reality a little bit easier to take. Some questions you can ask to develop your plan and know what's going to happen is, what will treatment look like? When is it going to be? Will I have a biopsy? What do I need to do next? Do I need to make any appointments? And what are the possible effects on my vision? These are things, this is why I recommend a notebook, because these are all vital questions that you are going to have at some point in your treatment journey. And you'll want those answers. And a lot of the time, there's so much information being thrown at people that we just forget the answers, or we forget we even ask the questions sometimes. It's just a lot to take in. So I recommend developing a plan with your treatment team, looking for what steps do you need to take versus what steps they're going to take to make sure nothing's forgotten. So we're going to talk a little bit about who is who in your treatment team. So first, I'm sure many of you are aware of your ocular oncologist. So the next one on there is vitreoretinal specialist. And sometimes those terms get mixed up together. So vitreoretinal specialist and ocular oncologist are not quite the same. Every ocular oncologist is a vitreoretinal specialist, but not every vitreoretinal specialist is an ocular oncologist. Being an ocular oncologist takes extra training, fellowships in ocular oncology from specialized training programs. A vitreoretinal specialist has advanced training as a vitreoretinal surgeon. After medical school and residency, they do a fellowship in retinal surgery. So they're still pretty darn smart, but they don't necessarily have all the experience in ocular oncology itself. Often they do help co-manage patients who don't live as close to the ocular oncologist. They can treat things like radiation retinopathy and side effects from your radiation treatment. Next is the oculoplastic surgeon. Now, if you've had an eye removed or something like that, often you went to an oculoplastic surgeon. They're basically a plastic surgeon who specializes in eyes and faces. So they like to make things look really pretty when they're done. Next up is the radiation oncologist. So if you had brachytherapy or plaque, or even proton beam radiation, you have likely met with a radiation oncologist. So first, they're trained as oncologists, but then they're specially trained after that in therapeutic radiation to treat or cure cancer. So there's a difference between the radiation oncologist and the medical oncologist. The medical oncologist is the one you'll see who will help plan out your treatment for systemic imaging of your body throughout the next 5, 10, 15 years. They're also going to be the ones to help do biopsies, treatment, or testing if there are any metastatic lesions that do show up. They also are the ones who recommend clinical trials and adjuvant therapy trials. So they're pretty important. Next, we have a genetic counselor. So patients who are high risk or have a family history or have a biopsy that's concerning generally get recommended to see a genetic counselor. What a genetic counselor does is they can do extra testing on your blood and your genes and your DNA, see if there's any other markers there that may be of concern to you or your family. So highly recommend that. Next and last up, we have our navigator or advocate. So these folks are lay people. They're not doctors, but they connect us with all of our other specialists. They make sure our records go to the right places. They make sure that everything is authorized through insurance. They make sure we get scheduled places. And they're your person to talk to when you have a concern, a question, an issue, or sometimes you just need somebody to talk to and have your back. That's who you want to talk to. Now, the biopsy. So this is just a quick overview of the biopsy from Castle Biosciences. We offer our patients a biopsy, which is generally performed at the time of treatment. And we do that because the biopsy doesn't tell us if there's melanoma or not. It tells us the prognostic factor, which is what does the future look like? And so there are a few possible results with that testing. As you can see, there's class 1A, class 1B, and class 2. Now, there's also the PRAME gene, which has been introduced, but there is no solid data yet, which gives us numbers as to how that changes the survival at 5 years. It's just a little bit too new still. Now, a diagnostic biopsy can be done in cases when, in a clinical setting, diagnosis is not as obvious, or it's a question, or it's requested by the patient, but it does require surgery. So if we don't need to do it, we don't. Now, for class 1A patients, we generally don't immediately refer them to medical oncology unless they're PRAME positive, which increases the risk factor. We just don't know by how much, which is why we say, hey, you should probably see a medical oncologist and get some systemic imaging set up for every few months and some lab work. If a patient is 1A or 1B, we have clinical visits with the ocular oncologist every 3 months for the first year, every 6 months for the second year, then annually after that. NCCN, which is the National Comprehensive Cancer Network, guidelines recommend imaging to evaluate signs and symptoms and surveillance imaging every 6 to 12 months for 10 years, then as clinically indicated. Now, for class 2, we definitely refer them to a medical oncologist for continued surveillance. And the surveillance imaging is recommended every 3 to 6 months for 5 years, then 6 to 12 months for 10 years, then as clinically indicated. We also recommend asking your medical oncologist about adjuvant therapy or clinical trial. And we'll get into kind of what the difference between those two are in just a few slides. We also recommend considering referral for genetic counseling if you are that high risk. Now, what do you do if your physician doesn't follow these recommendations and doesn't order your imaging every 3 to 6 months for the first 5 years, and they want to do something different that's farther apart? First, ask why. If there's a good reason for it, or if they're just not aware of what the recommendations are. Next, ask if they're open to changing their plan. Now, most wonderful doctors like to take their patients' opinions into consideration, and they're always open to learning. So if they're not aware of the guidelines, then we can show them. These are the suggested guidelines for a patient in my situation. And then you can go from there. And now if your physician says, nope, I'm not going to do it, that's it, you may decide that maybe you would want to see another doctor to request that imaging for you if you're not comfortable waiting that long. Now, here is a copy of the NCCN guidelines that was just updated in 2020 for uveal melanoma. And this shows for low-risk patients, medium-risk patients, and high-risk patients what those recommendations are that we just went over. So I highly recommend everybody kind of make yourself aware of what those guidelines are and those recommendations. And I can make this available to Lauren and Leanna at MRF if anybody else wants to take a closer look, because I know there's a lot of writing there. So we talked about clinical trials and adjuvant therapy. So adjuvant therapy is treatment that's used after your primary tumor in the eye is already treated. It's used to prevent the spread of cancer. Currently, all adjuvant therapy options, though, are in the clinical trial stage. Clinical trials, depending on what stage the disease is currently at, there may be clinical trials available. They offer patients treatments which may not be standard of care. However, most of the current studies are for what we call advanced uveal melanoma, so ocular melanoma that has already spread within the body. Now, I do recommend discuss with your medical oncologist what trials you may qualify for, and if you participate in those, would they preclude you from participating in any other future trials? You can look at current studies on the MRF website, and I put a little link here under the Participate in Science link, and you can contact the enrolling facility for their requirements as well. Now, sometimes when your doctor requests imaging for you, the insurance says no. They just deny the imaging. In that case, your doctor's office can file an appeal. I just put a sample letter here of one of our appeal letters that we have sent out before to insurance companies to cover a PET CT that was done for initial staging. If after the appeal, the insurance company still denies that authorization, what can happen is your physician can do what's called a peer-to-peer consultation with the medical director at your insurance company. Those are often where decisions are reversed. So in my experience, we've had a lot of times where the minute a doctor gets on the phone with another doctor, they just agree and they'll say, oh, okay, that's fine, go ahead. But it's getting to the point of getting that peer-to-peer, which can take sometimes weeks. There's a lot of bureaucracy wrapped up in all of it. But I definitely recommend always appeal. And if your doctor's office is slow to do so, ask them to. If they tell you it was denied, tell them, can you appeal it? Because some may not and some may. Our policy is we always fight until the bloody death with insurance companies because they don't want to pay for anything. So sometimes we have to force them to. So there's just a little sample there on how those kind of look. Now, if you move, transitioning to a new doctor, it can be terrifying. It's out of our comfort zones and things like that. So there's a few things you can do to make that transition just a little bit easier. First, before you move, ask your current doctor for a recommendation on who you should see. Often, they know a lot of the doctors around the country. This is a rare disease, it's a tight network of ocular oncologists who pretty much all know each other. And they may know who might best fit with your personality or your case itself. Also, I recommend getting a hard copy of a transition letter, which outlines your treatment plan. And I'll show you a sample one of those on the next slide. Next, get direct contact information for the medical records department to make sure that your records are transferred seamlessly. So often, you'll go to have your appointment with another office and they'll say, we don't have any of your records. So you want to verify that's done before you have that appointment. Also, read reviews of the specialists in your new area and solicit opinions from trusted peers, people you've met through different symposiums, conferences, online forums, things like that. Those opinions and experiences can be valuable. Once you've done all that and you've picked a provider, make an appointment with your new provider and make sure to check if they're in network with your insurance. To do that for yourself, you'll need the name, the address, and what's called the NPI number of your new physician. And that's a National Physician Identifier number. Every doctor has one, and it's not private information. You can even Google it. Once you've made that appointment, contact your previous provider's office to transfer all of those records and confirm that they're received by the new office before your appointment. At your first appointment, make sure you let the new provider know about your transition letter. Bring that copy with you that you have, and also let them know what your expectations are for your future care plan. Sometimes different doctors have different protocols for patients. This doctor may say, we do imaging every 12 months, and you feel you need it every 6 months. Let him know him or her know that is your expectation and that you would prefer to be imaged every 6 months. Often a doctor any doctor is going to say, okay, that makes sense and that's appropriate. All you have to do is ask sometimes. So here's a sample transition letter. So this is one that I have written, and it just has our main phone number on it, but for many patients, and it just says what we're following a patient for, what they were treated with, what the genetic result was from the biopsy, and how often we've been imaging them and they need to be imaged in the future, and what that imaging should be, whether it's contrast enhanced MR or ultrasound of the liver. So we also put our contact information in case there's any questions. But this can be vital depending on if you go to one doctor after you move and you don't like them and you want to go to another doctor, you'll still have that letter, which tells them what needs to happen for your future care. And that's priceless. So I'm just not that into you. Like we just talked about, sometimes a doctor is just not the one for you. So what do you do if you feel like your doctor is just not the right fit? So the doctor-patient collaboration is like an LTR, a long-term relationship. It's okay if they're just not for you. It's okay to break up with them. And it's okay to let your expectations and boundaries be known. It's okay to ask for change. If your treatment plan is not what you want it to be, and it's not the appropriate treatment plan that you feel, ask for change. You can always ask for a second opinion. Excellent doctors don't mind. That's how healthcare, medicine, science advances, is a lot of doctors think very differently. And all of those different thoughts and opinions come together, and that's how we advance. And it's wonderful. And you can also, if you're really unhappy, you can just have your care transferred to another physician. Nobody's going to look poorly on you, and it's okay. You have to remember that this is your life and your livelihood. And 5 seconds of a doctor's hurt feelings or funny look or anything doesn't matter compared to that. Also, before you leave, make sure you sign a release so your records can be sent to whatever new physician you'll be going to. That's step 1 in your process for moving on. Next, here we go. We have some just additional patient resources. Melanoma Research Foundation website, there's all kinds of resources with different webinars, links to resources, the clinical trials that we talked about. You can search for some in your area there. Always look at the patient navigators or advocates at your treatment center. Their whole job is to have your best interest in mind. So they're always a great resource. There's the American Cancer Society, which has some funding options, housing options, and things like that. There is the Patient Advocate Foundation. So if you're having trouble getting your co-pays paid, your insurance coverage, or prescriptions paid for, you can contact the Patient Advocate Foundation. They can help you do that advocacy. There's also online forums on various social media platforms. That can always be great. I stress to use it with caution, because remember, not everybody is an expert, but almost everybody thinks they are. So when you're on social media, it's great to talk about how you feel about things, people's experiences, but be cautious when asking for advice. You should always go to your physician first. And then there's also organized support groups. The Melanoma Research Foundation runs a virtual support group with Thomas Jefferson University social workers every month. And we also run the Ocular Melanoma Support Alliance every month, which is a virtual discussion platform with speakers. So if you're interested in any of those, you can go on the Melanoma Research Foundation website and they can help you get all that set up. And thank you. So I am going to try and stop my screen sharing. Here we go. So I am going to look at some questions here and see if I can scroll. There we go. So, okay, can patients ask for all of their documents via an online portal? That varies by the office. Not all offices have an online portal. Not all offices can upload documents to it. So I would always recommend getting a hard copy and then scanning them in yourself. That's just the safest way to go. Let's see, during COVID, what can patients do if they can't bring a caregiver or someone with them to the visit? So we've had that happen a lot in our office. And what we recommend is having somebody either on speakerphone, or you can actually Zoom them while you're in the room. Just because they're not physically there doesn't mean they're not there. So still important to have that support system. Sometimes it just has to be a little more virtual. Let's see. If you have conjunctival melanoma, will there be any other people in the treatment team that differ from OM? So that depends on where you are. Some practices are more cohesive than others, and they have the team all set up already. And some ocular oncologists don't treat conjunctival melanoma. They would bring in an oculoplastic surgeon, like we mentioned earlier. They can also help with that. And then there's also general ophthalmologists who do kind of front of the eye stuff, and they can help treat the conjunctival melanoma as well, depending on how your doctor is going to treat it. Sometimes it may be enucleation, which is removal of the eye, and sometimes they just remove the lesion itself and use different types of lasers. So it depends on what the treatment plan is. Let's see. Will genetic testing lead to further metastasis due to biopsies? Absolutely not. They have studied this time and time again. It does not enhance the likelihood that your cancer will spread by having a biopsy. It just doesn't. They've studied it, they've looked at it, and there is no correlation between the two. That's a tough question. Can a doctor fire a patient if they don't agree with their surveillance or protocol? So, like I said, your relationship with your doctor is like a long-term relationship. And in a long-term relationship, either party can end the relationship at any time. So that's why I recommend having that conversation and not just going along with what they say. And that goes vice versa. It should be a collaboration between the two of you. It shouldn't just be a dictator relationship. This is your body, your choice. There are different protocols all over the country. So everybody has a little bit of a different way about it. And if you feel like something is right for you and you go to your doctor and he says no and fires you, I would say maybe that doctor wasn't for you in the first place. There are a lot of really wonderful experts out there. And sometimes it just takes getting with the right one. Also, if your physician, your ocular oncologist, is only ordering testing every 12 months, you can also discuss with your primary care doctor or your medical oncologist to order it on the other 6 months. So that way you're still getting it. It's a little bit more trouble, but if you really like your ocular oncologist and you guys just can't agree on that surveillance, that's another way to go about it. And let's see, some patients worry to go against their doctors because they are the experts. How should a patient prepare to talk to their doctor if they don't agree with their treatment options or surveillance and there's pushback from the doctor? So again, you just want to have a very frank conversation. So it's your body, it's your choice, and quality of life is very important. And if you don't feel like you're getting the care that you need, your quality of life is going to be reduced. So I recommend having a very frank conversation with them and saying, look, I found these documents. This says this is what is recommended, and I feel like I would like to do this instead. And 99 times out of 100, it goes pretty well. Insurance company keeps saying I need to see a melanoma specialist, but that person has no experience with OM. How do I work with the insurance company to see the right specialist that might be out of network? Oh, so that's a tough one. So when it's out of network, what you can do is work with your ocular oncologist to do what's called a network exception request. And basically what it is you file paperwork with the insurance company letting them know that that specialist does not have necessarily that specialty that you need, and you can ask to see the other specialist, and your ocular oncologist can do a peer-to-peer with them to explain that to them. And often it takes a little bit of time, but it's usually pretty successful. And then after your first visit, you can do what's called a continuity of care authorization. So I think I am out of time right now. If there are any other questions, I can answer them in the chat, but I will sign off here.